Hey, BC here. Thanks for watching BC Nephro. Today we're going to talk about an approach to the diagnosis of metabolic acidosis. For an overview of an approach to acid-base disorders in general, check out the video on this channel at BC Nephro or the link to an article at bcnephro.com. Link will be in the description below. But today we're talking about metabolic acidosis and approach to that diagnosis. First, we're going to go over the anion gap and the differential and some of the unusual things in the differential. Then we're going to talk about the osmolar gap, which helps in diagnosis of toxic alcohol ingestions, or at least to have a suspicion for those. And we're going to talk about the urine anion gap, which is used in the diagnosis of different causes of hyperkalemic or normal anion gap acidosis. So first of all, you have a metabolic acidosis. You know you have a metabolic acidosis because the pH is low, the bicarbonate is low, and the PCO2 is high, and you diagnose that's what you have there. The next step is to find out what the anion gap is. So we calculate the anion gap based on the sodium minus the chloride and minus the bicarbonate. So that usually there is more unmeasured anions than unmeasured cations. So usually that's somewhere in the ballpark of 8 to 12, could be a little bit lower. Now, if there's other anions that are accumulated that are not accounted for, that will increase the anion gap and suggest that there's something else that you need to look for that's causing the acidosis. So certainly if the anion gap is above 20, regardless of what else is going on, you need to be suspicious that there's an increased anion gap metabolic acidosis going on. Some important things to know about the anion gap. The main contributor to the anion gap is albumin. So if there's hypoalbuminemia, the anion gap may be misleadingly low, and you need to correct for that. So for every decrease in an albumin of 1, you correct by the increase in the anion gap by 2.5. So if the albumin is 2, then an anion gap of 15 is really the same thing as an anion gap of 20. Corrected anion gap would be 20 in that context. Now, there's mnemonics, and they'll be in the article at the link at BC Nephro, but one of the mnemonics I like, a gold mark. Now, we all know a lot of the things that cause metabolic acidosis. We all know that lactic acidosis, we can measure the lactate. We all know diabetic ketoacidosis, we can measure the beta-hydroxybutyrate. We all know that kidney failure causes an increased anion gap metabolic acidosis. We can see that's going on with the BUN and creatinine. We can talk about, but I'd like to talk about some of the other less common things. One of the less common things is a D-lactic acidosis. You need to be suspicious for, because if you order a lactate, that measures L-lactate, and that will be normal, but the D-lactate may be high. Now, this is in cases where there's some sort of bowel, short gut syndrome, bacterial overgrowth, and it's also associated with confusion. So if you have a patient with that clinical history, confusion, increased anion gap metabolic acidosis, you need to think about D-lactic acidosis and specifically order a D-lactate, which is typically a send-out test. Another thing is something called Pyroglutamic Acidosis, or 5-oxyprolenemia. And this is something that typically happens in elderly, malnourished, more often women who are on therapeutic doses of acetaminophen, and they come in with an increased anion gap metabolic acidosis. So what happens is the therapeutic doses of acetaminophen in this context deplete the glutathione, and this causes this type of metabolic acidosis. So in someone in this context, you would think about this diagnosis. You would treat with bicarbonate as well as N-acetylcysteine. And if you wanted to diagnose this, you would send out a urine organic anions, and that may give the diagnosis. But you're not going to, this is going to be a send out, and you're not going to get those back in a timely manner. So those are some of the things that are common enough that you need to think of in a hospitalized patient. The next thing, if there's an increased anion gap acidosis, you're going to want to see if there's an osmolar gap. So you're going to want to see if there's an unmeasured osmol, which is causing the anion gap acidosis. And the unmeasured osmols are typically alcohols, toxic alcohols. Now, there's 5 alcohols that I can think of that cause an increased osmolar gap. The osmolar gap is going to be the measured osmolarity, so you order an osmolarity in the lab and see what comes back, and the calculated osmolarity. And the calculated osmolarity is going to be composed of sodium and its corresponding anion, urea, and glucose. So what you do is you take the sodium, multiply it by 2, and then you take the BUN and you correct it for the molecular weight. You divide it by 2.8, the BUN divided by 2.8, and the glucose divided by 18. You add that up, you get the calculated osms, subtract that from the measured osms, and typically that's less than 10. If that's greater than 20, you have to think that there's some sort of osm going on there. And if there's a metabolic acidosis, you have to think that that might be causing it. So I'm going to talk about 5 alcohols. So there's ethanol, ethylene glycol, methanol, propylene glycol, and isopropyl alcohol. Now, 2 of those cause an increased osm gap and make you drunk, but don't cause a metabolic acidosis. And those are ethanol and isopropyl alcohol, which is in rubbing alcohol. And the reason is their metabolites are not an acid. When they're present, they cause the osm gap, but when they're metabolized, they're not metabolized into an acid. The other 3, ethylene glycol, methanol, and propylene glycol, they do cause an increased osm gap, and then they're metabolized into an acid, which would cause an increased anion gap acidosis. So ethylene glycol, typically antifreeze ingestion, so you're going to think about that in the right clinical context. You're going to look for an increased osm gap. Typically, if it's above 20 in the right clinical context, you're very suspicious. You can send out an ethylene glycol, but if you're really suspicious, you're going to need to treat while you're waiting for that to come back. Now, the other interesting thing about ethylene glycol is metabolized into glycolic acid. And glycolic acid is what causes the increased metabolic gap acidosis. Now, the thing is the blood gas analyzer misreads glycolic acid for lactate. So a quick way to maybe figure this out is do a blood gas and then send a serum lactate. So if the lactate is elevated on the blood gas but is normal on the serum lactate, it's called a lactate gap. That really suggests that ethylene glycol is present, and you have an increased osm gap, you have the acidosis, you're waiting for the send out, but you're really highly suspicious and institute treatment in that case. Another one is methanol. Methanol is in different types of solvents. The sterno, the little things for camping stoves and things like that you light on fire, has methanol. Some other things have methanol. Increased osm gap in that setting, you're going to think about that. Methanol is metabolized to formic acid, which causes increased anion gap acidosis. The third alcohol is propylene glycol, which is typically iatrogenic. Now, propylene glycol is usually in a diluent of certain IV medicines, IV drips. The most common ones are benzodiazepines, IV lorazepam, IV diazepam. If people are getting high doses of this for a prolonged period of time, the propylene glycol can accumulate. The propylene glycol is metabolized to lactate and causes the increased osm gap from the propylene glycol. The lactic acidosis causes the increased anion gap. Now, if the anion gap is normal and they're not hypoalbuminemic, and this is also referred to as a hyperkalemic metabolic acidosis, you're going to think about some other things. Now, the most common things that you're going to see are diarrhea and saline, iatrogenic if it's acute from saline resuscitation. Another thing you're going to think about is renal tubular acidosis, RTA. Now, one of the ways to diagnose this, if you have a normal anion gap acidosis, you're going to do a urine anion gap. Now, the main way the kidneys excrete acid is by excreting ammonium and H4+. That's the way they excrete acid. Since it's positive, it's going to need to come with something negative, which is chloride. So if someone has a normal anion gap metabolic acidosis, let's say from diarrhea, and the kidneys are responding appropriately, there should be a lot of ammonium in the urine. Now, urine ammonium is not measured. There's not a good way to measure that. So you deduce its presence by the urine anion gap. So what you do is you take the urine sodium plus the urine potassium and subtract the urine chloride. Now, if that formula comes out negative, then there's something else positive in the urine that's coming with the chloride, and that's most likely ammonium. That means the kidneys are responding appropriately, and you're thinking about diarrhea or some other extrarenal cause. If that is positive, that suggests there's not much ammonium in the urine, the kidneys are not responding to the acidosis appropriately, and then you're going to think about an RTA, some other renal cause going on. Now, some of the more unusual causes maybe to think about: ureteral neobladder or fistula. So what happens is that someone has a bladder cancer and has a surgery to make a false bladder using some sort of the colon. Now, the exchanging characteristics of the colon are not the same as the bladder. So if urine is sitting in that false bladder, which is made of colonic tissue for a prolonged period of time, there can be an exchange. The ammonium that's in the urine can come back into the blood. The hydrogen and chloride anions can come back into the blood, and bicarbonate and sodium can go from the blood into the urine, and that can cause a normal anion gap metabolic acidosis. So there you have it. General approach: anion gap. If it's elevated, start looking at the osm gap. If the anion gap is normal, look at the urine anion gap. Formulate your differential and some of the unusual causes we talked about. So there'll be a link to a more comprehensive article at bcnephro.com. Leave your comments and questions. If you like this video, give it a like, and so other people can find it. And thanks for watching. Until next time.